স্যার আপনি পারমিশন দিলে শুরু করতে পারি? স্যার Assalamu alaikum and very good evening to all. I, Professor Rubina Yasmin, Professor of Medicine, Mugda Medical College, would like to welcome you all to on the live webinar on symptoms analysis of neurological disorder, organized by MedExcel BD Academic Group, and Nuvista is today's scientific partner. The chairperson of today's session is Professor Khan Abul Kalam Azad, Chief Coordinator, MedExcel Academic Group. Emeritus Professor ABM Abdullah, Professor of Medicine, is our chief guest. We are very honored to have you, sir, with us. The panel of experts of today's session are many of our respected professors of medicine. And the speaker of today's session is the legendary Professor of Neurology, none other than Professor Quazi Deen Mohammad, sir, President, Bangladesh College of Physicians and Surgeons, and Director, National Institute of Neuroscience. Now I humbly request sir to enlighten us with his speech. Sir, please, you can start your speech now.
Okay, thank you very much, Professor Rubina, for introducing me in this floor. First of all, many thanks to the organizer for inviting me in this highest academic floor to speak on a very important and fundamental topic in neurology. As you all know, that neurology is basically a mathematics. That means there is a correct answer based on fundamental findings. And the fundamental findings are symptomatology, based on which you should look for it, answer the diagnosis. In neurology, symptomatology is basically is close to the disorder of normal function. As you all know that in neurology, there are different parts. And symptomatology means the normal impairment of normal function, that is dysfunction. When there is dysfunction of an organ, that dysfunction is actually presented with symptomatology. That is the fundamental basis of any disease so far. As you also know that symptomatology is basically based on the organ-based, that is the organ which is involved, and there are few and could be many systemic symptoms. In neurology, to be honest, I tell you, most of the symptomatology are organ-based. So we should know critically the neuroanatomy and neurophysiology of nervous system. Otherwise, it is very difficult to put a diagnosis on the findings of symptomatology. So as a result of that, I am now going to my presentation. Yes. So here I go. Here I see that actually what I have set in my mind, that how should I approach to this topic of symptomatology of neurological diagnosis. I felt that if I really describe the different functions of different parts of a body, a brain or nervous system, then I can discuss about the dysfunction, and then I can also say about the symptomatology. And if I first of all, as I mentioned, that before I start, I should go for a little bit of anatomy of the nervous system. All you know, the nervous system is basically divided in central nervous system and peripheral nervous system. The structures which lies within the perimeter is called central nervous system. The structures which lies outside the perimeter is called peripheral nervous system. And today I will discuss about almost all parts, central nervous system and peripheral nervous system. With the honor to time, I will try to finish my lecture in 1 hour. So I humbly request all of the panelists and all the participants, they might carefully listen to my topic. So first of all, you know the brain. Brain has cerebral hemispheres, diencephalon, brainstem, and cerebellum. In the hemisphere, there is frontal lobe, parietal lobe, occipital lobe, and temporal lobe, and diencephalon, basal ganglia, and thalamus. In the brainstem consists of midbrain, pons, and medulla oblongata, and cerebellum. This is a very gross anatomy, not a very detailed or minute anatomy. The next is the spinal cord, which has got three components: cervical, thoracic, and lumbar. As you all know, the spinal starts from the foramen magnum and ends in the lower border of L1 or the upper border of L2. That is why there could be a little bit small lumbar component. And now is the peripheral nerves, which contains cranial nerves and spinal nerves, and other is the autonomic nervous system. If you know that cranial nerves arises from the brain stem, but when it crosses the brain stem, it becomes a part of the peripheral nervous system. So when you talk about the peripheral nervous system, it means the cranial nerves and the spinal nerves. I will little bit address about the autonomic nervous system if I have time. Now I come to the topic. Yes, my dear participants, here I have discussed about the functions of different parts of the brain. That is really a very gross function because they have got many functions which are not clinically important. I have tried to put forward or focused on those functions, those are clinically very important. Frontal lobe, as you all know, that it functions mainly on voluntary motor movement, motor speech, executive functions like cognition, behavior, personality, and social sense. On the other hand, if there is impairment of functions of this part, what will cause? Then there will be weakness of opposite side of the body, motor dysphagia, forgetfulness, loss of social sense, abnormal behavior. So when a patient presents with weakness of opposite side, motor dysphagia, forgetfulness, and other part of cognitive impairment, that will point you to the lesion in the frontal lobe. Similarly, the parietal lobe, because obviously there is the brain hemisphere, right and left hemisphere, one is dominant, another is non-dominant. Usually, left hemisphere is dominant in almost all person, but in right-handed person, left-handed person, left hemisphere is also dominant about 90% cases. Coming to parietal lobe, which is, we all know that purely sensory, functionally, but anatomically there is different component. It is the perception of all modality of sense, and it has got receptive center for speech in the dominant side. So when there is parietal lobe lesion, there is impairment or loss of sensation in opposite side, and there is receptive dysphagia, which is classically known as anomic dysphagia. That means the patient cannot name the object. He can speak fluently, he can talk fluently, he can understand everything, but he cannot name the object. If you put a pen in front of him, he cannot name. If you put a watch in front of him, he cannot name. So this is called anomic dysphagia. And there is also, in addition, in the non-dominant parietal lobe, apraxia and agnosia. That means true identification of the object. That is a part of non-dominant parietal lobe dysfunction. So you see, whenever you see anomic dysphagia, immediately point the lesion in the dominant parietal lobe, area 39 and area 40. Coming to the temporal lobe, where there is accumulation of the language comprehension part, hearing, emotion, and memory. You know that when you discuss about the dysphagia, what will happen? If I ask one person, what is your name? Then he will tell, I will eat. What does it mean? The answer is not appropriate. I asked his name, but he told me that he will not eat. That this is called receptive dysphagia. Why there is problem in understanding? Because when I asked the question, what is your name? He heard the question through the auditory, through the ear, and this auditory radiation goes to temporal lobe. And there it is comprehended. That means what I am asking, that is understanding in the temporal lobe. When the lesion in temporal lobe, that is not comprehended. He doesn't understand what I am asking. So he answers in a different way. This is called sensory dysplasia or Varnick dysplasia, or this is called comprehensive language problem. As you all know, that in temporal lobe, this is in I think, the dominant hemisphere. But in addition, in the temporal lobe, there is a very important center, which is called recent memory center, which is called emotional center. So when there is lesion in the temporal lobe, there could be language problem, there could be memory impairment, there could be temporal lobe seizure, there could be hearing problem and emotional problem. So when there is lesion, they will produce sensory dysplasia, hallucination, delusion, memory loss, and complex Persian seizure that should be kept in our mind. Next is the optic or occipital lobe. As you know, occipital lobe basically consists important for the visual center. It is a center for visual processing. And when there is lesion in the occipital lobe, it gives rise to cortical blindness, Anton syndrome, and Berlin syndrome. Let me say something about the Anton syndrome, which is basically an inattention syndrome. That means there is lesion not in the occipital lobe, there is also in the parietal lobe. When there is combination or lesion, the connection between the occipital and parietal lobe, that gives the Anton syndrome. What is this? That is called visual agnosia, visual ataxia, and visual apraxia. Visual agnosia means the patient cannot find the object in his visual territory. Optic ataxia means patient cannot fix his eye to the object. Agnosia means patient cannot. Apraxia means cannot locate the object in the visual field. This is all of our sensory perception problem, inattention problem. And there is another syndrome which is called Berlin syndrome, which is really the cortical blindness. The patient is really blind, but he denies. So whenever we see a blind man, he cannot see anything really, but he denies blindness. He just makes some hallucination. Yes, I can see the color, I can see your shirt, I can see something, but this is some imaginary thinking. But this is called cortical blindness or Berlin syndrome. Here I should mention that if you have the lesion in one occipital cortex, that will produce hemianopia. If you have bilateral occipital cortical infarct, that will produce cortical blindness. Then the thalamus, which is the pacemaker of the brain. All sensations from different parts of the body are carried to the thalamus, except one, which is the first nerve, olfactory nerve. This thalamus then conveys all motor sensation to the cerebral cortex in the parietal lobe of the opposite side. And in thalamus, there is also a subcortical speech center. Subcortical speech center, which is a sensory conducting speech problem. When there is lesion in the thalamus, it will produce hemisensory loss, thalamic syndrome, thalamic dysplasia. Here I should clearly say that when a patient presents with a hemisensory loss at one side of the body, that is, diagnosis usually two. One, either lesion in thalamus or functional. In cortical, parietal lobe lesion does not cause hemisensory loss. I repeat, parietal lobe lesion does not cause hemisensory loss. Because cortical lesion, the fundamental principle is a focal lesion, is a focal presentation. So hemisensory loss has two diagnoses, thalamic lesion or functional. Similarly, there is also a thalamic dysplasia, which is a sensory conducting dysplasia, and another syndrome, which is thalamic syndrome. Following stroke, about 30% patient may have a excruciating pain, which is burning in nature, that is occurring in the hemiplegic side, in paralysis side, and that is very, very refractory to the treatment. I usually tell to my student that if a doctor can cure thalamic pain, he will get the Nobel Prize. He will get the Nobel Prize. Because this pain is so distressing. Patient often and on comes for the solution, but we are really helpless. The other thing is that, remember, for the student, thalamic lesion does not cause hemiplegia, but clinically, we see hemiplegia in a thalamic stroke. This is because of internal capsular involvement, which lies just lateral to the thalamus. Keep in mind. So thalamic lesion itself does not cause hemiplegia, but in practice, we see hemiplegia in a thalamic stroke or hemorrhage, but this is because of internal capsule lesion. Coming to the basal ganglia, we said the most important function is defining motor movement. And involvement of basal ganglia, popularly, it causes resting tremor and other involuntary movements, depends on the structure involved and the rigidity. The classical triad of resting tremor, involuntary movement, and rigidity gives and puts to a diagnosis of Parkinson's disease. But remember, all of the basal ganglia has different parts. Different part produces different type of lesion. If it is spotted nucleus, it causes chorea. If it is an putamen, it causes dystonia. If it is subthalamic nucleus, it causes thalamic. There is also a subcortical speech center. Subcortical speech center, which is a sensory conducting speech problem. When there is lesion in the thalamus, it will produce hemisensory loss, thalamic syndrome, thalamic dysplasia. Here I should clearly say that when a patient presents with a hemisensory loss at one side of the body, that is, diagnosis usually two. One, either lesion in thalamus or functional. In cortical, parietal lobe lesion does not cause hemisensory loss. I repeat, parietal lobe lesion does not cause hemisensory loss. Because cortical lesion, the fundamental principle is a focal lesion, is a focal presentation. So, hemisensory loss has two diagnoses, thalamic lesion or functional. Similarly, there is also a thalamic dysplasia, which is a sensory conducting dysplasia, and another syndrome, which is thalamic syndrome. Following stroke, about 30% patient may have a excruciating pain, which is burning in nature, that is occurring in the hemiplegic side, in paralysis side, and that is very, very refractory to the treatment. I usually tell to my student that if a doctor can cure thalamic pain, he will get the Nobel Prize. He will get the Nobel Prize. Because this pain is so distressing. Patient often and on comes for the solution, but we are really helpless. The other thing is that, remember, for the student, thalamic lesion does not cause hemiplegia, but clinically, we see hemiplegia in a thalamic stroke. This is because of internal capsular involvement, which lies just lateral to the thalamus. Keep in mind. So thalamic lesion itself does not cause hemiplegia, but in practice, we see hemiplegia in a thalamic stroke or hemorrhage, but this is because of internal capsule lesion. Coming to the basal ganglia, which said the most important function is refining motor movement. And involvement in basal ganglia popularly, it causes resting tremor and other involuntary movements, depends on the structure involved and the rigidity. The classical triad of resting tremor, involuntary movement, and rigidity gives and puts to a diagnosis of Parkinson's disease. But remember, all of the basal ganglia has different parts. Different part produces different types of lesion. If it is choroid nucleus, it causes chorea. If it is an putamen, it causes dystonia. If it is subthalamic nucleus, it causes thalamic hemivalismus. It is a basal ganglia hemivalismus. Substantia nigra lesion causes Parkinson's disease. So there are different anatomical components, and lesion produce different type of presentation. Coming to cerebellum, it is a wonderful organ lying outside the mainstream of the brain, but it coordinates the brain. Its main function is coordination and equilibrium. And the dysfunction of the cerebellum causes intention tremor, dysdiadokinesia, dysmetria, dyssynergia, hypotonia, scanning speech ataxia. Among all these, most important hallmark of cerebellar lesion is intention tremor. Intention tremor. I tell you that in case of cerebellar disease, if a patient presents with unilateral, and here I tell you that cerebellar symptoms is usually ipsilateral, but cerebral and brainstem lesion usually contralateral. But usual cerebellar ipsilateral lesion, when a patient presents with unilateral acute cerebellar lesion, unilateral acute cerebellar lesion, diagnosis is three. One is stroke, second is hemorrhage, third is trauma. There could be many other things. I think he who is a very good clinician who thinks very minimum possible diagnosis, not a big or wide list of diagnoses. So clinically, when a patient presents with acute unilateral cerebellar lesion, diagnosis is stroke, acute stroke, abscess, and there is trauma. When there is bilateral acute cerebellar presentation, first diagnosis is infective. First diagnosis infective. Second is toxic. And third is metabolic. On the other hand, when there is chronic unilateral cerebellar feature, first diagnosis is ICSON, intracranial space occupying lesion. And second diagnosis is cerebellar congenital agenesis, or AVN, or vascular malformations. And when there is bilateral progressive cerebellar lesion, the diagnosis is either degenerative, mostly degenerative, then second is hypothyroid. But never, ever forget about paraneoplastic syndrome. The cerebellum is the hallmark or key part that is involved in the brain in paraneoplastic syndrome. In paraneoplastic, without any other reason behind, there is cerebellar presentations. And these cerebellar presentations clinically may be very difficult to exclude from other possibilities. But when you go for MRI, in paraneoplastic, the cerebellum will be normal. In spite of normal MRI cerebellum, there is cerebellar dysfunction that gives high suspicion of paraneoplastic syndrome. Coming to midbrain, which is a very small 1 centimeter, 1 inch in diameter. Midbrain, there are important few structures: the third, fourth cranial nerve, ascending and descending tract, reticular activating system, and pupillary fiber. Obviously, when there is lesion to the midbrain, there could be cranial nerve palsy, as for example, third, fourth cranial palsy, involvement of the descending tract, the ascending tract, involvement of the reticular activating system, and also the pupil. kills the people. One thing that when there is lesion in the midbrain, the common causes of lesion in the midbrain is stroke. Second is the trauma. Third is the infection. And fourth is the tumor. Stroke is the most important cause. So it gives rise to few syndrome that cause the Weber syndrome, Claudius syndrome, Benedict syndrome, North-Nagal syndrome, Perinaud syndrome. And in the Weber syndrome, as you all know, that there is involvement of the third nerve, ipsilateral third nerve, contralateral hemiplegia. The classical presentation of brain stem involvement usually give rise to cross paralysis. That means ipsilateral hemiplegia and contralateral ipsilateral cannular palsy and contralateral hemiplegia. That is characteristic features of brain stem lesion. So in midbrain, there are a few syndromes, which is Weber syndrome, where there is third nerve palsy, ipsilateral third nerve, contralateral hemiplegia. In the Claudius syndrome, that is ipsilateral third nerve and ipsilateral hemiplegia, but an ipsilateral cerebellar ataxia because of involvement of ascending spinocerebellar tract. The Benedict syndrome, where there is third nerve palsy, ipsilateral, contralateral hemiplegia, and involuntary movement. In the North-Nagal syndrome, the third nerve palsy and ipsilateral and contralateral ipsilateral cerebellar findings. So what happens here? Third nerve, fourth nerve is always involved, but the syndromes are separated depending on the hemiplegia. Somewhere it is hemiplegia, in the Benedict it is ataxia, and in the North-Nagal it is involuntary movement cerebellar type. Coming to Perinaud, where there is involvement of the medial midbrain syndrome, where there is defect in the upward and downward movement of the eyeball. When there is lower part involvement, midbrain, lower part, failure of upward gaze. When there is upper part involvement, failure of lower gaze. So that is a classical presentation of midbrain involvement. So whenever you see a third or fourth nerve palsy in a patient, then please examine to find out the features of tract involvement, either hemiplegia or involuntary movement or ataxia. Coming to the pons, 5th, 6th, 7th, 8th cranial nerves lies in the pons, along with the ascending and descending tracts and reticular activating system. And classical ponton lesion like the midbrain also give rise to the features of some brainstem syndrome, which is Miller-Gabler syndrome. Another is a Foville syndrome, pontine hemorrhage, and hearing loss. In the Miller-Gabler syndrome, there is 6th and 7th nerve involvement in the same side, and the opposite side there is hemiplegia. And Foville syndrome is very complex, where there is involvement of all the cranial nerves, 5th, 6th, 7th, 8th, all cranial nerves are involved, ipsilateral, and there is contralateral hemiparesis with the other, maybe they have involuntary movement. And there could be hearing loss, and there could be severe vertigo. And in the ponton lesion, vertigo is a very, very important presentation. And you all know the ponton hemorrhage, which is very common in stroke. About 4% patients may present with ponton hemorrhage, and in that case there is high fever, hemiplegia, and pinpoint people. Pinpoint people, pyrexia and paralysis, classical presentation of ponton hemorrhage. And look, everything depends on the classical examination, meticulous examinations. Whenever you see a cranial nerve involvement, that means there is something in the brain stem if there is finding of long-trunk deficit. Coming to the medulla oblongata, where we see quite often lateral medullary syndrome. In the medulla, lower cranial nerves are involved, 9th, 10th, 11th, and 12th cranial nerves, along with ascending and descending tract and descending sympathetic tract, reticular activating system. And the lesion in the medulla oblongata definitely produce cross paralysis, ipsilateral cranial nerve, contralateral hemiplegia. But there is a classical syndrome, which is Wallenberg syndrome or Pica syndrome, posterior, inferior, cerebellar artery involvement, where there is paralysis of the cranial nerves in one side, 9th, 10th, and 11th, and there is sensory loss in the opposite side. As a result, and there is also Horner syndrome, ipsilateral Horner syndrome, ipsilateral 9th, 10th, and 11th cranial palsy, and contralateral hemisensory loss. Remember, in the medulla, there is very, very difficult to have hemiplegia because the pyramidal tract in the brain stem, midbrain, pons, and medulla lies in the medial part. But almost all lesions involve the lateral part of the medulla. That is why pyramidal tract is spared, and as a result, there is no hemiplegia. Patient presents with sudden onset of acute dysphagia, sudden onset of acute dysphagia. Sensory complaint may be ignored. When you examine the patient meticulously, you might find the sensory loss. But when you examine the throat, you will definitely see palatal palsy and Horner syndrome. So presence of Horner, palatal palsy, dysphagia, and hemisensory loss gives the diagnosis of Pica syndrome or Wallenberg syndrome. Here I should mention one thing. What is the function of reticular activating system that extended from the midbrain up to the upper part of the medulla, mostly in the pons? Reticular activating system is concerned for the awareness of a person. When it is involved, there is impairment of the awareness. When there is unilateral lesion of reticular activity system, that produces semicoma. When there is bilateral involvement of reticular activating system, that produces coma. So when a patient presents with coma, then you analyze, is it a structural lesion or something other than structural lesion? Remember, structural lesion, there is coma and involvement of the brain, of the pupil. But in other causes of coma, beyond the structural causes, people is usually spared. People is usually, so coma with sparing of the people, most likely non-structural lesions. But coma with involvement of people, most likely it is a structural lesion. Remember, in medicine, there is no hard and fast rule. But in poisoning, as you all know, there could be involvement of people. In spontaneous hemorrhage, there is involvement of people. But there are few exceptions. But in general, this is the reality. The another thing is, now coming to spinal cord. Remember, when there is involvement of the brain as a whole, that means global involvement of the brain, global, not focal. Many lesions produce as focal, stroke, tumor, trauma, anything. But there are other causes of global involvement of the brain. When there is global involvement of the brain, presenting as encephalitis, encephalopathy, disorientation, restless, incoherent talk, no focal sign, fever, the cause is usually fine. Global involvement of the brain, no evidence of focal, cause is usually fine. 1, infective, 2, toxic, 3, metabolic, 4, hypoxic, 5, traumatic. 5, traumatic. Many a times trauma does not give rise to focal lesion. Blunt trauma or deep-seated trauma may not give rise to focal lesion. So when there is a global presentation, global impairment of brain, Usual causes is fine. I beg apology. There could be many other causes beyond this, but always keep in your mind these 5 causes of global involvement of the brain. Next is the spinal cord, which is spinal cord extends from the, as I mentioned, from an magnum up to the lower border of L1 or upper border of L2. It is divided structures contain of anterior horn cell, posterior horn cell, and important tracts. Among which there are few columns, lateral column and posterior column. In the lateral, remember, I should say one thing. There are many structures in the spinal cord. All are not equally important. All are not clinically important. So you should keep in mind the most important tracts and their functions. So I have tried to mention all these possibilities. One, anterior horn cell, posterior horn cell, and in the lateral column, most important lateral corticospinal tract, ascending spinothalamic tract, dorsal and ventral, sorry, it should be ventral spinocerebellar tract. In the posterior column, classically tract of Gall and tract of Buddha. All of know that what is the functions of anterior horn cell? It is a lower motor neuron cell. When the lesion in the anterior horn cell, it causes wasting, adiflexia, fasciculation. Remember, fasciculation is a hallmark for anterior horn cell involvement. We can rarely see fasciculation in peripheral nerve involvement, but rare thing rarely happen, common thing commonly happen. So whenever you see fasciculation, it will point you to the anterior horn cell, unless proved otherwise. When the lesion in posterior horn cell, it causes sensory impairment, all models of sensory impairment. And the other tract, you know, lateral corticospinal tract, it carries the pain, touch, and temperature. And cortical tract, descending motor tract, which is called pyramidal tract. It comes from the cerebral cortex up to the anterior horn cell to the opposite side. It causes the motor function, conveys the motor functions. And the ascending spinothalamic tract, as you all know, it carries the pain, touch, and temperature from the opposite side of the body. And dorsal and ventral spinocerebellar tract, it carries ipsilateral, unconscious, proprioceptive impulse. I repeat, it carries ipsilateral, unconscious, proprioceptive impulse. Coming to posterior column, tract of Gall and tract of Buddha, gracilis and fasciculus. They carry ipsilateral pain, vibration, position, and half touch, fine touch, vibration, position, and fine touch from the same side of the body. The tract of Gall, lower half, and tract of Buddha, upper half. So why I am telling this anatomy and the function? Because if you do not know the respective function of a tract, it is very difficult to point out the lesion. This is, as mentioned, that beside this, but clinically, in the spinal cord, we divide the cord in a complete cord lesion, hemisection of the cord, or Brown-Sequard syndrome, or lateral cord syndrome, or central cord syndrome. As I have shown you the picture in the last slide, you can see the central area that is called, this is a central area, this is a central area, this is a lateral area, this is a posterior area. So lesion could be in the posterior area, lesion could be lateral area, lesion could be central. In the central, it is called central cord syndrome. If lateral cord syndrome. If it's complete spinal cord, complete cord syndrome. And if it's one half of the cord, is called hemicord syndrome. So according to the involvement structures, there will be the clinical presentations. In the central cord syndrome, classically, bladder is involved first. There is also involvement of pain and temperature fiber. In the hemicord, there is ipsilateral, the ipsilateral pyramidal tract side and contralateral spinothalamic side. In addition, there is also a anterior horn cell or posterior horn cell lesion. Remember, how can we really localize the spinal cord? Next, before that, I also tell you that spinal cord lesion usually causes bladder involvement. There is definite sensory loss, spinal shock in acute cord lesion, spastic quadriparesis when there is cervical cord lesion, spastic paraplegia, thoracic cord lesion, Unas medullaris, with the lesion T12 to L2 syndrome is a mixed. You can find a combination of upper motor and lower motor features in the legs along with bladder involvement. Also a Cora equina syndrome, which also causes the 12 lumbar 12 to lumbar 2 to coccyx up to all lumbar 2 to all coccyx and up to the coccyx nerve, sectal nerve and coccyx, all nerves are involved. That is typically lower motor neuron type. There is adaplegia, sensory loss, along with bladder involvement. So difference between the conus and cauda. Conus is a cord lesion, lower cord lesion. And cauda is a radicular lesion. So in the cord lesion, combination of upper motor, lower motor, and cauda only radiculopathy. That is the main difference. And bladder involvement also there. There are other points of difference that is very not important. But remember, whenever you see a spinal cord lesion, how can you really localize? First of all, you decide, is it a cord lesion? From this presentation, blood involvement, sensory level, and others. What is the lesion? Usually, the site of lesion is identified on the basis of three signs. At the level of lesion, there is lower motor neuron feature because of involvement of anterior horn cells. Here, below the lesion, there is upper motor neuron sign because of pyramidal tract involvement. And also, there is definite level of sensory loss because of spinothalamic tract lesion. These three will guide you to find out the site of lesion. Remember, if you see a case of paraplegia or quadriplegia, if you clinically examine the patient to find out the site of lesion, if you do not examine the spine, your examination is incomplete. So, spine examination in case of paraplegia, quadriplegia is a must. Remember it. Because simple spine examination will definitely give you a diagnosis. If you see the gibbous, then you can put a diagnosis. So that is the important. There is spinal shock. Acute spinal cord lesion may produce spinal shock. That means there is loss of power, loss of tone, loss of reflex. But then how will you differentiate this spinal shock from Guillain-Barré syndrome? Off and on. Usually there is mistake from the students. The Guillain-Barré syndrome also present with quadriplegia. But acute spinal shock in the cervical cord lesion may present with quadriplegia. Then how will you differentiate? Listen carefully. Differentiation is based on three things. First, bladder involvement. In cord lesion, the blood involvement, but in Guillain-Barré syndrome, usually no blood involvement. If there is blood involvement in Guillain-Barré syndrome, consider other diagnosis. So first of all, blood involvement. Second, plantar. Plantar might be absent, but it could be extensor in the presence of all ducts absent. And third, sensory loss. So you can really differentiate if you really examine the patient meticulously. There is nothing beyond your examination. Next, I come to another chapter, which is called the cranial nerve involvements and spinal nerve. And I am really worried that whether I can finish in time, because the cranial nerve and spinal nerve is a very, very big chapter. Very big chapter. And I feel this class is not only for the recapitulation of my favorite colleagues, but also for the postgraduate students. So this is basically what I have seen. I have tried to address in detail of all. May not be full coverage of the scenario. So let us start. Cranial nerve. First cranial nerve, anosmia and parosmia, may not be clinically important, but in the COVID, that has really teach us and our point attention to the picture of anosmia. The first and early presentation of COVID could be anosmia. There are other presentations of anosmia, frontal lobe tumor, atrophy of the nasal mucosa, polyp. There are different causes. The second cranial nerve, which is very, very important and very, very important for the neurology particularly. In the second cranial nerve, we see dimness of vision or loss of vision. There could be papilledema or there could be optic atrophy. Whenever you see a unilateral papilledema in one eye, that could be due to optic neuritis, posterior Kennedy syndrome, retinal venous thrombosis, and anterior ischemic optic neuropathy. When the bilateral papilledema, remember, most important cause is raised intracranial pressure. Next is idiopathic intracranial hypertension, anterior ischemic optic neuropathy, optic neuritis, and hypercapnia syndrome. So, clinically, whenever you see unilateral or bilateral, then you can define possibly what might be the cause. Similarly, optic atrophy, when the unilateral optic atrophy, posterior Kennedy syndrome, optic neuritis, anterior ischemic optic neuropathy, and traumatic. But when there is bilateral optic atrophy, it could be the consequence of raised intracranial pressure, idiopathic intracranial hypertension, anterior ischemic neuropathy, PES syndrome, and hereditary metabolic. This could be toxic. This could be the most important cause of bilateral optic atrophy. I should mention here that I request my students to look into the fundus very, very meticulously, which is often ignored. Then is the dimness of vision. Dimness of vision could be two types. One could be complete loss of vision, or could be loss of part of the vision, anopia. When there is loss of part of a visual field, that could present with anopia. This anopia is hemianopia. When there is heteronymous hemianopia, that means bitemporal visual field impairment, the lesion lies in the cellular area. When there is bitemporal visual field loss, the lesion lies in the cellular area, most common pituitary adenoma. Then the other lesion lies there. When there is homonymous hemianopia, lesion usually lies retrochiasmal, optic tract, and occipital cortex. So, when there is impairment of vision, decide, is it hemianopia or it is, if it is hemianopia, it is homonymous or heteronymous. If heteronymous, lesion here. If homonymous, lesion there. Coming to the dimness of vision, total loss of vision. When there is unilateral total loss of vision, that is one eye visual loss, the lesion lies either in retina or in optic. Monocular blindness is lesion lies either in optic nerve or in retina. But when there is biocular visual impairment, lesion lies in the chiasma or retrochiasma. So that is a gross difference between the two, monocular and biocular. That should be kept in mind. So when there is transient monocular visual loss. What are the causes of? A patient complains of sudden onset of blindness, persists for a few minutes, then goes. Monocular. The causes are migraine. Most important cause is M. erucis fugax, or which is called TIA, carotid artery TIA. Then it's migraine, cerebral hypoperfusion, seizure, press, visual obscuration, the age ICP, and head injury. Monocular transient visual loss. Monocular non-progressive visual loss. Retinal artery occlusion, anti-ischemic neuropathy, posterior ischemic neuropathy, trauma, and functional, hysterical blindness. When there is progressive monocular visual loss, progressive, the first one is transient, second one non-progressive, third one is progressive. Optic neuropathy due to other causes, optic neuritis, toxic and metabolic. Remember, dear friends and my students, I have tried to consider the most common causes. There could be many other causes of this kind of lesions, but as a clinician, I think you should consider as minimum as possible as a differential diagnosis. Then biocular transient visual loss, cerebral hypoperfusion, migraine, seizure, pituitary apoplexy, press, functional, acute raised ICP. Then biocular non-progressive visual loss, occipital infarct, bilateral optic neuropathy, pituitary apoplexy, head trauma, functional and toxic. Biocular progressive visual loss, optic neuritis, compressive sarcoidosis age ICP, hereditary optic neuropathy, toxic, metabolic paraneoplastic. These are the common causes of visual impairment. Coming to the third nerve palsy, which could be unilateral and which could be bilateral. So if you have unilateral third nerve palsy, unilateral third nerve palsy is usually due to trauma, tumor, PCOM aneurysm, and stroke. Bilateral third nerve palsy, stroke, tumor, GBS, CIDP, Lyme disease, and Miller-Fisher syndrome. Similarly, fourth nerve gives rise to vertical diplopia and trauma, because the most important cause is trauma. So when there is a ptosis, I should say, third, fourth, and sixth cranial nerve usually discussed together because they supply the extraocular muscles and the pupil. Whenever there is a third, fourth, and sixth nerve palsy, they may present with ptosis, diplopia, nystagmus, squint, and pupillary changes. There could be a third nerve actually. Third nerve causes all of this. Sixth nerve may not cause, does not cause ptosis, but does not cause pupillary changes. Fourth nerve does not cause ptosis, does not cause pupillary changes. So third nerve may cause all of this. Fourth nerve only cause the diplopia or nystagmus, squint, and sixth nerve may cause diplopia, nystagmus, squint, but may not cause, does not cause ptosis and pupillary changes. So third nerve palsy unilateral, that could be due to causes that I mentioned. Fourth nerve, fifth nerve palsy. Fifth nerve, I am talking now about peripheral. These nerves coming from the brain stem passes through the spaces, and lesion in these spaces may cause fifth nerve, trigeminal neuralgia, heartbeat, hemifacial sensory loss, weakness of muscles and mastications. Sixth nerve could be unilateral and bilateral. In the unilateral sixth nerve, maybe diabetes, viral, tumor, stroke, bilateral raised ICP, GBS, CIDP. Remember, when there is unilateral sixth nerve palsy in a young man, unilateral sixth nerve palsy in a young man, it is nasopharyngeal carcinoma unless proved otherwise. Unilateral sixth nerve palsy in a young man, it is nasopharyngeal carcinoma unless proved otherwise. When there is bilateral sixth nerve palsy, it is because of raised ICP unless proved otherwise. They are the key and guideline which should consider in front whenever you see the patients. This is a complete ptosis in left eye. Remember, complete ptosis is always a nerve lesion. It never occurs in myasthenia. It never occurs in myopathy. A complete ptosis is always a nerve lesion. It never occurs in myasthenia gravis. It never occurs in myopathy, ocular myopathy. You see, because of third nerve, the eye has deviated outside. This is bilateral, you see, bilateral ptosis, more marked right. This is a classical case of myasthenia gravis. Incomplete bilateral ptosis, maybe unilateral, incomplete unilateral ptosis. Diagnosis commonly two. One is myasthenia gravis, two, Horner syndrome. And three could be partial third nerve. Three could be partial, of course, exclusion of the congenital one. The bilateral, similarly, partial ptosis also. You see the bilateral partial ptosis, as I mentioned, the left sixth nerve palsy. The eye has deviated to the medium, left sixth nerve palsy. That is bilateral sixth nerve palsy. Eye has deviated. The classical bilateral sixth nerve palsy, so the eye has deviated towards medially. So deviation of the eyeball toward the nose, medial squint, is a bilateral sixth nerve palsy. Then coming to the third, fourth, and sixth nerve involvement together, as I have mentioned, when you see a case of ophthalmoplegia, third, fourth, and sixth nerve, patient cannot move the eyeball. If the pupil is normal, considered myasthenia gravis. If the pupil is involved, considered nerve paralysis. And to find out the site of lesion, third, fourth, and sixth, you should also examine the fifth nerve. First division of the fifth nerve and second division of the fifth nerve. So when the third, fourth, and sixth nerve involved, the lesion cavernous sinus, superior orbital fissure syndrome. In case of cavernous sinus, third, fourth, sixth, and first division of fifth nerve. In case of superior orbital fissure, third, fourth, sixth, first and second division of fifth nerve. So you should examine the fifth nerve as well. When there is third, fourth, sixth plus second nerve, Toloshahan syndrome, orbital apex syndrome. That second nerve passes through the orbital apex, involve Toloshahan syndrome and orbital apex syndrome. And seventh nerve, as you all know, Bell's palsy, bilateral, GBS, AIDP, unilateral, bilateral. Here I should mention one thing. Sometimes we see bilateral facial nerve palsy. This could be very early presentation of GBS. Very early presentation of GBS. When there's eighth nerve palsy, obviously unilateral hearing problem, and could be unilateral or could be bilateral, and consider about the present with severe vertigo when there is vestibular involvement, and giving the diagnosis of benign paroxysmal positional vertigo or Meniere disease, and consider eighth nerve palsy if this along with fifth nerve palsy, CP angle tumor. CP angle tumor. Eighth nerve, unilateral eighth nerve, and unilateral fifth nerve, maybe seventh nerve. This is a picture of CP angle tumor. 9th, 10th parietal palsy, as you know, if you examine, patient can develop with dysphagia, hoarseness of voice, and the 12th nerve, this ipsilateral tongue palsy. When there is 9th, 10th, 11th together, this is called jugular foramen syndrome, and could be involved in basal meningitis, myasthenia gravis, and polymyositis. I should focus more a little bit on the 9th, 10th, and particularly the 12th cranial nerve. All of you know that 12th cranial nerve ipsilateral produces the deviation of the tongue to the same side. When there is bilateral tongue palsy, maybe upper motor neuron, maybe lower motor neuron, please consider motor neuron disease. Motor neuron disease, commonest cause of bilateral 12 nerve palsy. They present with speech problem, swallowing problem, and features of pseudobulbar palsy. Pseudobulbar palsy. So you will see this is the really picture. You should examine whether there is a single nerve involvement or combination of nerve involvement. When a single nerve, different pathology, combination, different pathology. That is the reality. Then as I told you that third, fourth, sixth, first division, I have mentioned earlier that I have mentioned third, fourth, sixth, and first and second Toloshan syndrome, orbital fissure syndrome, second, third, fourth orbital apex. This is already I mentioned. Second, third, fourth, fifth, and sixth, Jacquot syndrome, retrospinal spaces. So series of cannula involvement. Second, third, fourth, fifth, sixth is a Jacquot syndrome. The lesion lies in retrosphenoidal space. Rarely we see unilateral all cannula involvement, first to 12. First to 12 unilateral cannula involvement. That is because of chordoma. Because of chordoma. That chordoma usually may present with hemicranial syndrome. There's fifth and sixth, I mentioned, I don't want to repeat. Fifth, eighth, seventh, ninth, CP angle tumor, ninth, jugular foramen, this is already I have mentioned. Now I am coming to the peripheral nerves. I think I have almost come to the end. Maybe I need further 5 minutes or 7 minutes. Then I want to finish. This is a picture that shows how a spinal nerve is formed. You can see here that this is anterior horn cell, posterior horn cell. This is ventral root, this is dorsal ganglia, dorsal root. The dorsal root and ventral root from the ramus. This trunk divides dorsal rami and the ventral rami. All these ventral rami from the plexus, upper limb and one limb. Dorsal rami goes back, paraspinal meninges. And these nerves are enriched by sympathetic component, white rami and gray rami. This is how the spinal nerve is formed. Why I have put this picture here? Because if you consider the spinal nerve is a mixed nerve because they contain sensory, motor, and autonomic component. So whenever you consider a peripheral nerve involvement, spinal nerve involvement, obviously there will be a combination of motor deficit, sensory deficit, and autonomic deficit. Sensory component coming from is dorsal root, motor component coming from ventral root. Here mixture of all and the division contains all components. So usually the peripheral nerves are mixed nerve. Maybe rarely motor and sensory predominant presentation. No definite level of sensory loss. It is only the dermatom. Dermatom-wise sensory loss. No blood involvement except chorda equina. More distal presentation than the proximal, and the classical types of mononeuropathy, mononeural multiplex, and polyneuropathy. In case of motor signs, there could be wasting, areflexia, fasciculation, and sensory sign tingling, paresthesia, numbness, pain and needle sensory loss, autonomic, hair fall, on the skin color changes, color change, brittle nape, decreased sweating, and postural hypotensions. The common causes of mononeuropathy is compressive, traumatic, vasculitic, diabetes mellitus, and leprosy. And mononeural multiplex, again, leprosy, diabetes, vasculitis, immune-mediated. The most important is polyneuropathy, which is common cause diabetic, toxic, metabolic, deficiency, malignancy, drugs, CIDP, GBS, many causes, many hundreds of causes of polyneuropathy. Remember, whenever you see a case of polyneuropathy in a young, consider familial Charcot-Marie-Tooth disease. In the middle age, consider toxic and diabetic. In elderly, consider paraneoplastic syndrome, besides the common causes of polyneuropathy. I have come to the last slide, where I have showed that how can you proceed to a case of paraplegia or quadriplegia. In a case of paraplegia or quadriplegia, decide, is it upper motor or lower motor? If it is upper motor and if there is bladder involvement, then if there is bladder, consider if there is upper motor, then look for bladder involvement. When there is involvement of the bladder, consider acute transverse myelitis, spinal swell, Conus medullary syndrome. When there is no blood involvement, consider degenerative, toxic, genetic motor neuron disease. When there are other things, when there is not blood involved, peripheral cord lesion, not lateral cord lesion. Coming to lower motor type, involve the bladder, consider the bladder. If lower motor, bladder is involved, then diagnosis spinal shock, cauda equina. If bladder is not involved, consider peripheral neuropathy and muscle disease. This is a simple flow chart that may not be sufficient, may not contain many of the aspects, but in the bedside, if you keep in your mind, I think many times you can come to a diagnosis. And finally, ladies and gentlemen, my colleagues, what I can tell you, the neurology is a mathematics. Please look into the pictures and findings and try to correlate these findings to the underlying part of the brain which produces this kind of functions. And lastly, remember, always we treat the patient, not the investigations. Keep in your mind what you see in examination, that is your mandate, and try to put a diagnosis initially on those findings. With these few features, I thank everybody for patience hearing. If anything left, I sincerely apologize. If anything not clearly understood, I again apologize for my inability. Thank you very much.
Thank you, sir, for your brilliant presentation. Around 300 postgraduate students is with us now. They will be very much benefited from your lecture. Now, this is the time for expert opinion from our panelists. I am requesting Professor M.A. Foy, sir, to give your opinion. Is Foy, sir, is there? I think Foy, sir, is not present here. Now I am requesting Professor M.A. Jalil Chaudhary, sir, for your valuable opinion.
And thank you, Professor Rubina. Okay, to my slide টা বোধহয় Prof Deen Mohammad সাহেব আপনার স্লাইডটা অফ করে দেন। থ্যাংক ইউ, আমরা আপনাকে এখন দেব, আপনি তো দিয়ে রাখছেন।
আচ্ছা, ঠিক আছে।
Thank you, Professor Rubina, for calling me first না, তার নাই দেখে আমি ফার্স্ট হয়ে গেছি এখন। Professor Khan Abul Kalam Azad for accommodating so much participants and expert panel in this webinar, and requesting Professor Deen Mohammad to deliver a speech, though his busy schedule. আমি কিছু বলবো না, কারণ আজকে আমাদের সময় শিক্ষকবৃন্দ আছেন কথা বলার জন্য, এবং অনেক ছাত্ররা বোধ আছে, প্রশ্ন নিয়ে আছে, আমি বললে সময় নষ্ট করবো না। শুধু একটাই বলবো, প্রফেসর দীন মোহাম্মদ রাজি হয়েছেন এটাই বেশি আজকে কথা বলার জন্য। হি ইজ অ্যান ইনস্টিটিউট, এক কথায় বলতে গেলে বেশি ওনাকে অত অল্প সময় ওনার পরিচয় দেওয়া সম্ভব না, আর দরকারও নাই, কারণ আপনারা ওনাকে সবাই চিনেন। এক কথায় বলবো হি ইজ অ্যান ইনস্টিটিউট, একটা ইনস্টিটিউটের নাম এখনো নেই। দ্বিতীয় কথা হলো, এই নিউরোলজি আমাদের সময় আমরা সবসময় নিউরোলজি ভয় করতাম, এবং সেই ভয়টা কাটিয়ে উঠছে দীন মোহাম্মদ এর যোগ শুরু হওয়ার পর থেকে আমার মনে হয়। এই যে ম্যাথমেটিক্স কথাটা উনি বললেন, প্রথমেই বলছেন ম্যাথমেটিক্স, আটার দ্য ওয়ার্ড ম্যাথমেটিক্স, এটা কিন্তু কত সুন্দর, এই ইজি এই নিউরোলজি, এটা উনি যখন নিউরোলজি হাল ধরছেন তারপর থেকে শুরু হয়েছে। আমার বড় শখ ছিল অনেক ক্লাস করার জন্য, কিন্তু দুর্ভাগ্য হোক সৌভাগ্য হোক কোনোদিন অনেক ক্লাস পাইনি বা করার সুযোগ পাইনি, কিন্তু সেই সুযোগ আমি হাতছাড়া করি নাই। যখন আমি বঙ্গবন্ধুতে কাজ করতাম তখন এক সময় চিন্তা হলো যে ওনাকে দিয়ে আমি কিছু ক্লাস নেই, উদ্দেশ্য হলো ওনার ক্লাসটা করা আর ছাত্রদের উপকার হবে। সুতরাং হি ওয়াজ কাইন্ড এনাফ দ্যাট উনি 2-3টা ক্লাস নিয়েছিল। এখন তখন দেখতে পারছি যে ম্যাথমেটিক্স কাকে বলে, অঙ্ক কাকে বলে, এবং অঙ্ক কিভাবে মিলাইতে হয়। তবে অঙ্ক কষ্ট হলে মিলাইতে হলে কিন্তু যেটা উনি শেষে বলছে সেটা হলো যে ফাইন্ডিং ইলিসিট করতে হবে। এই যে থার্ড না ফোর্থ না ফিফথ না অঙ্ক যোগ করে দিলেন, কিন্তু থার্ড ইলিসিট বাইরে করতে হবে, এবং সেই ইলিসিট বার করার জন্য যে মিলেলে হবে না। তো যারা ক্লাস করে নাই, আমি জানি না নিউরোলজিস্ট এখানে অনেক আছেন, তারা মনে কষ্ট পাবেন কিনা, তারা আমি মনে হয় না তারা খুব ভালো নিউরোলজিস্ট হইতে পারবেন। তবে এখনকার যারা নিউরোলজিস্ট তারা ওনার ছাত্র, কোনো সন্দেহ নেই, এবং তারা সবাই ভালো নিউরোলজিস্ট, কোনো সন্দেহ নেই। ওরা হয়েছে কথা বলা যাবে, এই জন্য আমি বলতে পারি আমার নিউরোলজি পড়া কোনো হয় নাই, কিছুটা চেষ্টা করছি কভার করার জন্য, 2-3টা ক্লাস দিয়ে সেটা কোনো সময় কভার হয় নাই। তো সুতরাং দীন মোহাম্মদ সাহেবকে অনেকে ধন্যবাদ দেবেন। আমি আর শুধু আমি মনে করি যারা করেন নাই ওনার ক্লিনিক ক্লাসটা করার সুযোগ কোনো সময় যদি পান আপনারা হাতছাড়া করবেন না। আমি আর কিছু বলে সবার বিরক্তি উৎপন্ন করতে চাচ্ছি না, কারণ আমি জানি অনেকে কথা বলবেন। ধন্যবাদ প্রফেসর দীন মোহাম্মদ সাহেব আপনাকে আসার জন্য এখানে, এবং আমার সমস্ত শ্রদ্ধাভাজন পরীক্ষকদেরকে এবং ডিআর পার্টিসিপেন্টদেরকে শুভরাত্রি।
Thank you, sir, for your brief opinion. Now I am requesting Professor Quazi Tariqul Islam, sir, for your opinion. Sir, please.
Thank you very much. আসলে দীন মোহাম্মদ স্যারের লেকচার তো মনোমুগ্ধ হয়ে শুনছিলাম। It was a masterly presentation, no doubt, and স্টুডেন্টদের জন্য তো অত্যন্ত উপকারী হয়েছে। আর আমরা যারা শিক্ষক আমাদের অনেকটা রিফ্রেশার হিসেবে অনেকটাই ভূমিকা রেখেছে। এবং ওনার বলা, এবং উনি শুরুতেই বলেছেন যে আমি 1 ঘন্টা সময় নিব, এবং সে 1 ঘন্টা সময়ের মধ্যে হোল নিউরোলজি মোটামুটি একটা বল মাঠে ছেড়ে দিয়েছেন। খেলার দায়িত্ব হচ্ছে এখন যারা প্লেয়ার তাদের, অর্থাৎ যে ক্লিনিশিয়ান, যারা পরীক্ষার্থী তাদের। এবং স্যারের একটা জিনিস আমার কাছে খুব ভালো লেগেছে, সেটা হচ্ছে যে জায়গায় এমফাসিস দেওয়ার দরকার সেটা উনি রিপিট করেছেন। আই মাস্ট অ্যাপ্রিশিয়েট যে আমরা অনেক সময় এগুলো মনে রাখি না। আর দ্বিতীয় শেষের দিকে উনি একটা কথা বলেছেন যে ডু নট ট্রিট দি ইনভেস্টিগেশন, রাদার দি পেশেন্ট and the clinical sign or symptom that we got. Thank you, sir, that we got the opportunity to listen to your lecture. Thank you very much.
Thank you, sir. Now I am requesting Professor Soed Atikul Haq, sir, for your opinion. Atik sir was there, but probably now sir is not here. Now
I'm
sir,
still here.
sir,
No problem.
sorry, sir. Sorry,
No,
sir.
nothing. Yeah, actually, I couldn't check the temptation to utilize the opportunity of your offer. I thank the organizers first, for arranging such an excellent webinar. In fact, neurology is a bit more complicated subject, and that's why in our undergraduate courses, emphasis is not given to training of the nervous system disorders. That's why when I had been an examiner of FCPS Part 2 exam, as a part of the oral examination, I always used to keep a question on the nervous system disorders at the end. And most of the time I could not reach up to that end because most of the students are stuck up at that point. And when I used to reach the neurology, then most of the students failed to answer. That is a very sad part. And also students used to come to me in IPGMR or BSMMU after having quite a long training in different medical colleges. And also I used to ask them about questions on neurological disorders or to examine parts of the nervous system. Most often I found that the trainees are not at all prepared to give answers to neurological issues or to carry out neurological examination. And even I think even now we go for testing our even postgraduate who have qualified in internal medicine or our branches of internal medicine. Most of the students, most of the specialists will fail to elicit plantar response. Am I correct, Dinu bhai?
Yes.
Yeah, that's very sad. Even I think many students will fail to perform properly ankle jerkers. These are very simple things, very simple neurological approach, but most of the conditions. It means the art of taking neurological history and neurological examination are grossly neglected in both of our undergraduate and postgraduate curricula. What Dinu bhai, actually Dinu bhai, he is my teacher, but I am used to referring to him as Dinu bhai. I'm sorry, I sincerely apologize.
No. Thank you.
And I should not address like this.
No. Take it easy, please.
আমরা যখন এফসিপিএস পার্ট 2 তে ছিলাম তখন কিন্তু দীন মোহাম্মদ স্যার আমাদের রেগুলার ক্লাস নিতেন এবং এটা ঠিক যে আমরা আমাদের বাকি সমস্ত কাজ যাই থাকুক না কেন, ওয়ার্ডে একজন রোগী খারাপ সেটাও বাদ দিয়ে আমরা ওনার ক্লাসে চলে আসতাম। উনি আমাদেরকে নার্ভাস সিস্টেম এমন সুন্দরভাবে পড়াতেন, ওগুলি কিন্তু আমার এখনো কানে ভাসে। যেমন উনি বলতেন যে গিলেনবারি সিনড্রোম, what are the evidences of activity of Guillain-Barré syndrome? এইভাবে তিনি আমাদেরকে মানে অঙ্কের মতন তিনি আমাদেরকে সবই অঙ্কের মতন পড়াতেন। ওনার টাচে না আসলে হয়তো এই নিউরোলজিটা আমার অতটা ক্লিয়ার হতো না। আমি বলবো যে আমাদের আসলে এই নিউরোলজি টিচিং আমাদের কিন্তু এটা খেয়াল রাখতে হবে, নার্ভাস সিস্টেম ইনভলভমেন্ট is not only occurs in primary disorders of the nervous system, they may also occur as a part of multi-system disorders, and that is quite common, that is not rare. So each and every internist or each and every, I would say, specialist in branches of medicine, I would say allied specialties like rheumatology, cardiology, must thoroughly acquire the practice of neurological history, and it should form our part of routine clinical assessment in the in our chamber practice also. Otherwise we shall miss the diagnosis. It often happens to me that the patient has come with some rheumatological complaint, but I see that he has actually a foot drop or wrist drop. That means he has some multi-system disease, and this picture is common with vasculitis. A few days ago also I came across one patient who presented with some other features of vasculitis. It was actually purpura, and along with purpura he also had some other feature, actually, which was he had microscopic hematuria in the history, and I found during examination that he has third, fourth, sixth palsy, superior orbital fissure syndrome. That was the case of superior orbital fissure syndrome. So I think each and every internist or subspecialist in the branches of internal medicine should practice, and this is not very difficult. I have gone through one textbook of clinical examination, American textbook, and in that textbook they have divided neurological examination into two parts. One is routine neurological examination, and that is customized, problem-oriented, problem-focused neurological examination, and they have it was mentioned there, with sufficient practice it is quite possible to complete routine neurological examination within 10 minutes time. Just 10 minutes is possible to do it within 10 minutes. So I think actually Dinu bhai has covered almost entire neurology in this 1 hour lecture. I would congratulate him. It was a very formidable task, but I would say this must be fragmented, and the education must be spread up to some appropriate level in fourth year, fifth year, and to the fullest extent in the FCPS or MD of internal medicine, to the fullest extent. And regarding the subject matter content, I don't have much to comment because, he's an expert neurologist. He has covered everything. Only one thing, I would like to add that, he has said structural brain lesions and non-structural. But there is, of course, Professor Deen Mohammad has correctly said that, this, neurology or entire medical science is full of fallacies. There are exceptions. And there is a popular neurological aphorism, stroke somewhere, stroke nowhere, stroke in cerebellum. So, when we think that the patient is having a stroke, but there is no focal sign, we must think of, cerebral stroke. Though it is not common, but it is not, it is not very rare. It sometimes happens. With these few words, I again thank the organizers, and also I thank our Professor Deen Mohammad or our Deen Mohammad sir for his excellent lecture. I have joined. I had many other jobs at this moment also, but I have left aside everything just to hear his lecture.
Thank you.
Thank you very much, sir, for your delightful speech. Now, I am requesting Professor Azharul Haq, sir, to give comment on sir's lecture. Sir, and some student had question. I give one of question to you. That is, what is the difference between progressive and non-progressive monocular blindness? How to differentiate clinically? Sir, please.
First of all, I'd like to thank my great teacher, Professor Quazi Deen Mohammad sir. শোনা যাচ্ছে?
স্যার শোনা যাচ্ছে স্যার।
বলো।
অ্যাকচুয়ালি স্যারের সম্বন্ধে আমি কি বলবো? স্যারের সাথে আমি 1983 থেকে 2020 পর্যন্ত একটানা ছিলাম, মাঝখানে কয়েক বছর পেরিফেরাল মেডিকেল কলেজ বা ডিস্ট্রিক্টে কনসালটেন্ট সময় বাদে। স্যার আমাদের নিউরোলজিক্যাল ট্রি তার সামান্য কিছু অংশ হয়তো আমরা। Today's lecture is thoroughly based on the localization of the neurological lesion as per symptoms. It is excellent. But in our perspective, postgraduate students actually know how to approach the symptoms of neurology. Symptoms in neurology, some are positive, some are negative. Positive like your convulsions, like your motor, like your pains, that is spontaneous. And negative like your motor weakness, like your loss of sensation, like your loss of power, like your loss of memory, like your loss of consciousness in that way. However, but I like to remind our postgraduate students who are here, not our renowned colleagues or our renowned sir. প্রথমে আমাদের পার্সপেক্টিভে বাংলাদেশের লোকের সিম্পটম প্রেজেন্টেশনটা বিজয়, এইটাকে নিউরোলজিক্যাল ডিসঅর্ডারে ফিট করতে হয়। আমার হাত পা ঝিমঝিম করে, মাথাটা দিয়ে ভাব বের হয়, এটা করে সেটা করে, এটা কতটুকু নিউরোলজি, এইটা আগে প্রথমে বুঝতে হবে। ফার্স্ট ইউ আর টু discover the neurological dysfunction what presents the patients, then we approach to the clinical diagnosis. Ultimate clinical diagnosis লাভ দেওয়া যাবে না। First you just have presented how to approach the lesion. প্রথমে নিউরোলজি ডিসফাংশনটা কি, এটা কি উইকনেস, এটা কি পেইন, এটা কি it might be related to the spinal cord, it might be to the brain, or it might be cranial nerve, it might be spinal. First you approach in that way, then where is the lesion, then you follow the lecture of the SARS. These are the things. Second, যে জিনিসটা প্রথমে বলছে বাংলাদেশের মানুষের সিম্পটম প্রেজেন্টেশনটা বিজয়। Many Professor Syed Atiqullah sir rightly mentioned that a complex or the compound symptoms or sign complexes, some are related to generalized medical disorder, some is actually you have the loss of memory or the memory dysfunction. Patient might have your uremic encephalopathy, might hepatic encephalopathy, might repeated electrolyte dysfunctions, then give rise to. Rather, you put the diagnosis to the particular the brain as a primary disease, not like that, in that way. So, first, what is the problem of the patient? Is it neurological or extra neurological? If it's neurological, then follow the lecture what presented our great teacher Professor Deen Mohammad sir. In that, I don't like to give, there are many experts. One question is put, what is monocular blindness?
What is the difference between progressive and non-progressive monocular blindness? How to differentiate clinically?
clinically monocular blindness here is very important. Monocular blindness is either related to your primary eye disease or the optic nerve, not beyond that. It is before your optic chiasma. Lesion is with it there. Progressive means what the diseases. It is like that of any compressive lesions or inflammatory lesions or any other thing that is progressive. As it is not bilateral, so generalized cause excluded. Then it is immunological, or it is compressive, or it is vascular, or like that you have to clinically take the history and examine and comorbidity analysis in that way. That is the thing you can, if the lesions are persisting and progressive, likely the localized lesion is there. If it may be episodic, then it's some disease of autoimmune or like that fluctuate with that way. So in this situation, I cannot extend furthermore. I like to say you are to, first it is primary eye disease or the neurological disorder. Sir has mentioned whether it is retinal disease or like a primary another eye disease like intraocular pressure raised in that way that is related with your ophthalmological problem, or it is optic nerve disorder. I have seen it is a vascular AON, repeated AON algibrite, or the chronic vascular ischemia, or there is any tumor that compressing it, or there is entrapment neuropathy, or it is immunological. In that way, you have to find it and correlate with your systemic finding that you can differentiate it. I don't like to extend. There are many, I have seen so many panelists, especially some are much intelligent than me. So again, I am thanking all the postgraduate students as well as our learned colleagues who are attending the sessions, as well overall the Professor Deen Mohammad. He has nicely covered all the neurological textbook, localizing the lesions in a very, very good way. Thank you all. Allah Hafiz.
Thank you, sir. Thank you very much. Now I am requesting Professor Mohammad Ismail Patwari, sir, for your comments.
Thank you. Thank you. Actually, I failed to attend the full lectures, but I attended the last portion. And Professor Deen Mohammad actually is unique in his lecture. And I think all the participants were benefited by his excellent deliberation. I think if the lectures are divided in parts, say only the peripheral neuropathy, only the central nervous system lesion, that will be more benefited. So I think if we arrange mass lectures, actually dividing in parts, then it will be more beneficial to all the participants. So thank you, sir, for your excellent deliberation, and we have enjoyed much. Thank you.
Thank you, sir. Thank you very much. Now I am requesting Professor Muhammad Khalilur Rahman for your opinion.
Assalamu alaikum. Good evening, everybody. I like to express my thanks to organizer as well as presenter. The presentation that is presented by Professor Deen Mohammad sir, our respected teacher, that may be good, better, or excellent. But I am not showing my courage to say like that. Rather, I want to say that by his presentation, many of us have benefited. So I like to express my thanks, gratefulness and greetings to him. Thank you, everybody. Assalamu alaikum. Already I have finished my comment.
Thank you.
Thank you very much. Now I am requesting Professor H.M. Nazmul Hasan, sir, for your comments. I am very much sorry, sir. I didn't see you in this panel, sir. Thank you. Sorry, sir, for this delay. Professor H.M. Nazmul Hasan, sir.
No, Professor. Thank you, Professor Rubina. আমি মনে হয় প্রফেসর দীন মোহাম্মদ স্যার তো স্যারের সবাই এতভাবে প্রশংসা করতে থাকবেই। স্যার একাডেমিশিয়ান, ফিজিশিয়ান, অ্যাডমিনিস্ট্রেটর, ম্যানেজার সব মিলে একজন মানুষের ভিতরে এত গুণ থাকার এরকম দুর্লভ একজন ফিজিশিয়ান পাওয়া বাংলাদেশের জন্য কঠিন। এই জন্যই আমি নিজে বলবো, আমি যখন থার্ড ইয়ারে পড়ি তখন আমি স্যারের মনে আছে কিনা জানি না, কাজী স্যারের ওয়ার্ডে স্যার তখন ইন্টার্নশিপ করে। সেই সময় মেইন বেকার আর বিপিআই এদের একটা ছোট্ট নোটবুকে স্যার ইন্টার্নিদের ভাগ করে দিয়েছিল যে থার্ড ইয়ারের স্টুডেন্টদের পড়ানো সায়েন্সিস এর কজ, ক্লাবিং এর কজ, সেগুলি লিখে আমি মনে হয় পোস্ট গ্রাজুয়েশনে পর্যন্ত পড়ছি এবং পরেও আমার শিক্ষকতা জীবনে ওইটা আমি চালাইছি। তো আমি বলবো যে আমি যখন স্টুডেন্ট ছিলাম, সিএ ছিলাম, রেজিস্ট্রার ছিলাম, তখন পর্যন্ত দিনু ভাই বলতাম। নিজে যখন প্রফেসর হয়েছি তখন আবার স্যার বলা শুরু করছি। তো এটা আমি বলার উদ্দেশ্য হলো, স্যার যে বলতেছে যে এটা নিউরোলজিটা ম্যাথামেটিক্স এর মতো, আমি বলবো শুধু নিউরোলজি না, অন্য সাবজেক্ট গুলো কার্ডিওভাস্কুলার, রেসপিরেটরি, এই সবগুলো কিন্তু আসলে সিমটম সায়েন্স গুলো মিলতে হবে। 2 আর 2 যদি 4 না হয়ে 5 হয় তাহলে বুঝতে হবে যে কোথাও একটা ভুল আছে। আমি তো প্রফেসর মনিউদ্দিন স্যারের সিএ, স্যারও মনিউদ্দিন স্যারের সিএ। স্যার একটা কথা বলতো যে কখনোই পেশেন্টের কোনো সিমটম ইগনোর করবে না। এই জিনিসটা আমি সারা জীবন মনে রাখার চেষ্টা করছি, যে পেশেন্ট যে আসে আমাদের কাছে, সে তার অসুখ হোক, তার সে সাইকিয়াট্রিক হোক, সে একটা সমস্যা নিয়ে আসছে, তো এটা একটা লিসেনিং ইজ এ পার্ট অফ ট্রিটমেন্ট। এই জন্য মানে আমার হিস্ট্রিটা শোনা এবং সিমটম অ্যানালাইসিস করা, এটা আমার মনে হয় 70-80% কাজ হয়ে যায় ডায়াগনোসিসের হিস্ট্রি থেকে এবং সিমটম অ্যানালাইসিসে। আমরা মনে আছে সেকেন্ড পার্টে যখন ওয়ালিদা স্যারের ক্লাস করতে গেছি আমরা, তখন স্যার বলতেছে হোয়াট আর দ্য সিমটমস অফ নিউরোলজিক্যাল সিস্টেম। দেখি সবাই লাইন ধরে দাঁড়ানো, সবাই বলে প্যারালাইসিস, আর মাথা থেকে কিছু বাইর হয় না। এখন দেখি স্যার যে বলতেছে 1 ঘন্টার বেশি শুধু সিমটমই বলতেছে, যার ফলে আসলে নলেজের স্পেকট্রাম যে কতটুকু হওয়া উচিত। স্যার যে স্যারের ক্লাসটা নিউরোলজিটাকে স্যার জলিভাইও বলছে, সবাই এক বাক্যে স্বীকার করবে, আমরা যে সময় নিউরোলজিকে যেভাবে ভয় পেতাম, আর স্যার নিউরোলজিটাকে সত্যি সত্যি একটা অঙ্কের মধ্যে নিয়ে আসছে, এটা স্যারকে অবশ্যই ক্রেডিট দিতে হবে। এবং আজকের এই লেকচারের থেকে যারাই এখানে প্ল্যাটফর্মে আছে, স্টুডেন্ট হোক, টিচার হোক, আমরা সবাই আসলে মনোমুগ্ধ ভাবে এটা শুনছি। স্যার আপনি হোক, ভালো থাকবেন, আমাদের দেশের স্বাস্থ্য ব্যবস্থা আরো কন্ট্রিবিউট করেন। আপনাকে ধন্যবাদ দিয়ে আমি শেষ করছি। থ্যাংক ইউ স্যার।
Thank you, sir. Thank you, sir. Now I am requesting Professor M.A. Hassan Chaudhary, sir, for your comment. Probably Professor M.A. Hassan Chaudhary, sir, is not here. Now I am requesting Professor Ahmed Hossain for your opinion.
Assalamualaikum. It's actually Deen Mohammad sir is our teacher or our mentor, and he has presented this symptomatic analysis of neurological disorders. It's very amazingly, and we are really amazed. Actually, here I am not to comment on his lecture, but actually we were a listener to his presentation. And with this, I congratulate sir and organizers inviting me to be here as a panelist. Thank you. I'm ending my comment. Thank you very much.
Thank you, sir, for your comments. Now I am requesting Professor Muhammad Rafiqul Islam, sir, for your brief comment.
Assalamu alaikum. And I would like to express my gratitude and thanks to Professor Rubina, Professor Khan, Abul Kalam Azad, and other dignitaries. I see many of the panelists, including Professor Quazi Deen Mohammad sir and Professor Syed Atikul Haq sir, really taught us in part 1 and part 2 FCPS preparation. And one thing I always remember Professor Quazi Deen Mohammad sir used to say, always try to pick the hard points from history and examination. Say, for instance, bladder involvement in spinal cord disease. So I really found that during short case examination, neurological examination, careful examination always used to give a result. But I found respiratory system very often unreliable. So স্যারের মূল্যায়ন বা প্রশংসা করার ক্ষমতা আমার নাই। স্যারদের দীর্ঘ জীবন কামনা করছি। সবাইকে ধন্যবাদ। আসসালামু আলাইকুম।
Thank you, sir. Now I am requesting Professor Mohammad Mahfuzur Rahman for your comments.
Thank you, madam, for giving me opportunity. Really, it's a nice session, and through this opportunity, I'd like to express my thanks and gratefulness to the today's organizer, especially Professor Khan Abul Kalam Azad sir and the MediExcel, to organize such an extraordinary session. And we know that Professor Deen Mohammad sir, he is the teacher of the teacher, and he used to make all the classes which we have attended make the topics is so easy and so melodious. The neurology becomes the topics of interesting one. This class is very extraordinary and very much impressive. I think all of the teachers as well as all of the students are benefited and refreshed from his presentation. And I would like to again express gratitude and thanks to all of the teachers, and I would like to request Professor Khan Abul Kalam Azad and other organizers to make 2 or 3 more classes from Professor Deen Mohammad sir again, so that all will be benefited again. With these few words, I'd like to conclude my speech. Thank you and thanks for your kind attention.
Thank you, sir, for your brief comments. With this, we are at the end of opinion from our expert panel. Now it is the time for chief guest. Probably sir is not present here, so I am requesting Dr. Sanjida Ahmed for product presentation of Nuvista. Dr. Sanjida Ahmed.
Assalamu alaikum. Thank you for calling me. It's an honor to be here in this webinar with all of our legendary doctors of our country. And from Nuvista team, I would like to express my gratitude to all the doctors. We had 300 participants in today's webinar for your kind time and the effort you have given in our webinar. Actually, I'll take a few minutes to introduce one of our brands with you, which is Magnus 365. Nuvista Pharma has proudly introduced it for the first time in Bangladesh. It's basically magnesium oxide. We're calling it the magnanimous magnesium. The strength is 365 milligram and the dosage form is tablet. The price is 5 taka per tablet. The indication and uses of our Magnus 365 is basically as a supplementation in magnesium deficiency or hypomagnesemia, supplementation in pregnancy to prevent complications like preeclampsia, spontaneous abortion, GDM, low birth weight. As a supplement in clinical conditions known to be associated with magnesium deficiency, for example, vitamin D deficiency, type 2 diabetes mellitus, in cardiovascular health, supplement in severe asthma, COPD. And as a treatment to treat the conditions like migraine, treatment for pregnancy. And the recommended dose for patient over 12 years of age is 1 to 2 tablets per day and should be taken with meals. Usually it is well tolerated, not associated with any severe side effects. Diarrhea may occur usually with overdose and occasional abdominal cramps were reported. About uses in special populations is contraindicated with severe renal failure, and there is no data about use in patients with liver failure. It is safe in pregnancy. It is usually indicated in first and second trimester, and it is expected in breast milk in small amounts, so risk-benefit ratio should be assessed before prescribing. Now, why Magnus 365? Because it has higher intracellular absorption and most concentrated form of magnesium, meet the recommended dietary allowance with 1 to 2 tablets per day. Better compliance in comparison with other magnesium preparation available in market. And these are the clinical benefits in a nutshell, that it significantly improves pregnancy-related complications, support healthy bone, and activates vitamin D, prevent and reduces migraine headaches, helps to prevent depression, and most concentrated form of magnesium, which fulfills the RDA minimum dose. Thank you for your patience here.
Thank you, Dr. Sanjid Ahmed, Executive Medical Affairs, Nuvista Pharma Limited. Now it is the time for vote of thanks. I am requesting Mohammad Kamal Hussain Shorkar, Zonal Head, Nuvista Pharma, to give vote of thanks.
Yes, Assalamu alaikum. Today, master class, Honorable Keynote Speaker, Professor Quazi Deen Mohammad Sir, Honorable Chief Guest, Emeritus Professor ABM Abdullah Sir, এবং Honorable Chairperson, Professor Khan Abul Kalam Azad Sir, and Honorable Panelists, Faculties, Moderator, and Student of MedExcel Academic Group, Assalamu alaikum. On behalf of Nuvista Pharma, as the academic partner of MedExcel BD Academic Group, I would like to thank all participants. Especially very thanks to all faculties of MedExcel BD to give us the opportunity to work such an excellent academic platform. Actually, today I don't want to make any comments regarding this master class because I am too small to make any comments because there are a lot of teachers. But you know, sir, Nuvista Pharma is a very small company in Bangladesh, pharma market, and we are trying to make a science-based and academic-based pharmaceuticals company in Bangladesh. And we have a very big dream. Your continuous guidelines and support will help us a lot to move forward in the coming days. Thank you very much, sir, for your patient hearing.
Thank you, Mohammad Kamal Hussain Shorkar. At this time, I express my gratitude to Professor Khan Abul Kalam Azad Sir for giving me the opportunity to moderate this great session of Professor Quazi Deen Mohammad Sir. And I am grateful to all of them, those are present in this session. With this, I hand over my mic to Professor Khan Abul Kalam Azad for his speech as a chairperson and chief coordinator of MedExcel Academy. Sir.
Thank you, wonderful girl, Professor Rubina, আমার ছাত্রী আর শিক্ষক ছাত্রী এবং শিক্ষকদের শিক্ষক এবং এই কয়েক জেনারেশন মিলে আজকে যারা শিক্ষকতা করছেন, শিক্ষকদের বয়স হয় না, শিক্ষকরা পুরনো হন না, শিক্ষক যত বয়স বাড়ে ম্যাচিওর হন, আরো ভালো করে পড়ান। আজকে এই এত সম্মানিত একটি ওয়েবিনার যেখানে প্রফেসর কাজী দীন মোহাম্মদ স্যার আমাদের স্পিকার এবং দেশের শ্রেষ্ঠ শিক্ষকেরা আজকে যুক্ত হয়েছেন এখানে ওয়েবিনারে, এবং আজকে আমাদের প্রথমে কিন্তু প্রকাশ করছি যে আব্দুল্লাহ স্যার এখানে ছিলেন, ওনার একটা পারিবারিক প্রোগ্রামের জন্য উনি চিফ গেস্ট হিসাবে, তো উনি চলে গেছেন। আমরা আবার ঢাকা দ্বিতীয় অনুষ্ঠানে নিয়ে আসবো আশা করি। তিনি আমাদের সাথে সবসময় রয়েছেন এবং ছাত্রদীপ মোহাম্মদ স্যারের শরীর ঢাকা মেডিকেল কলেজে পড়ালেখা করেছেন। তো আমি স্যারের কাছে আগে একটু জানতে চাই যে স্যার আপনার নামটা স্যার আপনি বলবেন স্যার? মোহাম্মদ স্যার,
আজাদ ভাই আপনার স্পিকারের ওই যে স্টিকটা পিছনে গেছে মনে হয়, মাইকটা পিছনে গেছে, মাইকটা আপনার কানের কাছে মাইকটা পিছনে গেছে বোধহয়। হ্যাঁ, সামনে নিয়ে আসতে ওইটা, ওই যে খুলে দেখেন।
থ্যাংক ইউ। আমি প্রথমে আগে সমস্ত যারা আজকে উপস্থিত রয়েছেন এবং আজকে আমাদের নুভিস্টা যে কারিগরি সহায়তা দিয়ে সাহায্য করছেন, এটার জন্য ধন্যবাদ জানাই। সবাইকে, আমার সমস্ত শিক্ষকদের আমার প্রাণঢালা অভিনন্দন, আমি যারা পার্টিসিপেন্ট তাদেরকে অভিনন্দন। আমি এখানে দুই একটা কথা বলি। দীন মোহাম্মদ স্যারকে আমরা থার্ড ইয়ারের স্টুডেন্ট হিসেবে প্রথম পাই, সেই মুনিরুদ্দিন স্যারের ওয়ার্ডে। তিনি অত্যন্ত মানে কর্ম দক্ষ একজন অ্যাসিস্ট্যান্ট রেজিস্ট্রার ছিলেন স্যার। সেইখান থেকে আস্তে আস্তে তিনি পড়ানো শুরু করেন, সেখানে পড়াতেন। এটা 1 নম্বর। 2 নম্বর, আপনারা দেখবেন যে স্যার এই যে কোনো কিছু পড়াতে গেলে নাম্বার 1, নাম্বার 2, নাম্বার 3, নাম্বার 4 এবং উচ্চারণ করেন, তারপরে পড়ান। অর্থাৎ কি অসাধারণ মেমোরাইজেশন। তো স্যার যখন প্রফেসরের পিএইচডি দিয়ে আসলেন, তখন আমরা জিজ্ঞেস করলাম যে স্যার আপনাদের কি ধরলো? বলে রশিদুদ্দিন স্যার আমার মেমোরি নিয়ে বলতে বল। স্যার আপনার নিশ্চয়ই মনে পড়ে স্যার। তো মেমোরি, ওই যে মাথার মধ্যে মেমোরি ঢুকলো, যে মেমোরাইজ করাটা, এবং স্যার মেমোরির উপরে পিএইচডি তে বলেছেন এবং প্রফেসর হয়ে ফিরে এসেছেন, এটা একটা ব্যাপার। 3 নম্বর, আতিক স্যার যেমন বললেন যে আমাদেরকে পড়াতেন, আমরাও তাই। একদম নিউরোলজির, আমাদের যদি বলি যে ফাদার অফ নিউরোলজি বা প্রথম আমরা যে নিউরোলজি স্যার মান্নান স্যারকে দেখেছি, মান্নান স্যারের যেদিন ক্লাস হলো, প্রথম ক্লাস ইপিলেপসি নিয়ে পড়াতে গেলেন সেকেন্ড পার্টে, তো স্যারের দিয়ে একটা কথা বললেন যে দীন মোহাম্মদ স্যার বললেন যে আপনি পড়ান, বা তুমি করে বললেন স্যারকে যে তুমি দীন মোহাম্মদ তুমি ক্লাসটা নাও। তো ওই হইলো মান্নান স্যারের সাথে ক্লাস। এরপরে দীন মোহাম্মদ স্যার আমাদের পড়ালেন, আমাদের ওয়ার্ডে নিয়ে গেলেন। নিয়ে গিয়ে বললেন যে এটা একটা পেশেন্ট আছে, নিউরোলজির ফার্স্ট জিনিস কি, তুমি কথা কইতে কইতে ঢুকলা, রোগীর সাথে কথা কইলে আসসালাম আলাইকুম, আমার নাম এই, রোগী কথা বললো, তুমি কথাটা শুনে ফেললা। 2 নম্বর বললো যে আপনার টাইম পাউডার তোলেন, আপনার পাম্প পাউডার তোলেন। এইটা যে একটা কি বিচক্ষণতা, ওই প্রথম দিন শিখালেন যে নিউরোলজিতে তুমি আগে দেখে নাও যে মোটর কি অবস্থায় আছে, তারপরে আস্তে আস্তে সেন্সরিতে যাও। এটা হলো আমাদের দ্বিতীয় শিক্ষা। তারপরে আপনি দেখেন এই যে 3 নম্বর, যখন আমরা মেডেক্সেলে যখন করি, স্যারদের বললাম যে স্যার আপনি তো ক্লাস নিতে হবে, বলে অবশ্যই ক্লাস নেব। এক কথায় রাজি হওয়ার মানুষ, এই যে কত বড় জিনিস। তারপরে স্যারের টাইম নিলাম। এখন যখন এই যেহেতু আমি টপিকটা সিলেক্ট করি, আমি টপিক সিলেক্ট করতে গিয়ে বললাম যে দীন মোহাম্মদ স্যার কি পড়াইতে দিব, কি পড়াবেন ছাত্রদের জন্য, আমাদের জন্য। তাহলে প্রথমটা সর্বোচ্চ যেটা দরকার আমাদের এই যে সিমটম অ্যানালাইসিস, যে একেবারে শুরুতে ওই যে স্নেলস নিউরো অ্যানাটমি পড়েছিলাম, যে নিউরোলজিক্যাল ডিসঅর্ডার মানে হলো অ্যানাটমি ভালো জানা, ফিজিওলজি ভালো জানা, এবং সিমটম জানলে একজন ডক্টর কুইকলি ডায়াগনোস করতে পারে এবং আননেসেসারি ইনভেস্টিগেশন করা লাগে না, এবং একটা ডায়াগনোসিস দিয়ে রোগীর চিকিৎসা ইমিডিয়েটলি শুরু করা যায়। আমরা যখন ছাত্র, ডাক্তার, সিএ, রেজিস্ট্রার, সিটি স্ক্যান কোথায়, দীন মোহাম্মদ স্যারের সিটি স্ক্যান কই, এমআরআই কোথায়, এই স্যার আমাদের পড়াইছে সিটি স্ক্যান এমআরআই ছাড়া, রুবিনাদের আমি পড়াইছি হইলো সিটি স্ক্যান এমআরআই ছাড়া। স্ট্রোক কি ডায়াগনোসিস করি নাই, করছি তো। তারপরে আস্তে আস্তে প্রবলেম হয়েছে, বিভিন্ন রকম নিউরোলজিক্যাল ডিসঅর্ডার। তাহলে এটা হলো সিমটম অ্যানালাইজ। আমি মনে করলাম যে স্যারকে দিব সবচেয়ে এবিসিডি, কিন্তু সবচেয়ে দরকার যেটা মূল্যবান, ডাক্তাররা যেন এইটা ভুলে না যায়, এই সিমটম অ্যানালাইজ। তখন স্যারের জন্য এই টপিক সিলেক্ট করলাম এবং স্যারকে এটা দিলাম। এবং স্যার দেখেন আজকে যেটা পড়ালেন। আর একটা কথা বলি, আজকে যখন স্যারের কাছে একজন আমাদের এক্সপার্ট প্যানেলের একজন বাংলাদেশের বিখ্যাত নিউরোলজিস্ট, তিনি আজকে হঠাৎ করে একটা পারিবারিক প্রোগ্রাম পড়ে গেছে, উনি থাকবেন না। উনি আমারে রিকোয়েস্ট করলেন যে আমি তো স্যারের কাছে থাকবো না, স্যার এটা জানাইস না। উনি কিন্তু রিটায়ার করে গেছেন, বলতেছে কিন্তু স্যারের লেকচারটার কপি আমারে দিতে হবে, তো এইটা তুই আমার লেকচারটা দিবি। আমি চিন্তা করলাম এখনো স্যারের ছাত্র হওয়ার জন্য ওই রিটায়ার করে গেছে, কিন্তু ছাত্র হইলে খুশি হয়। তো এই হইল প্রফেসর কাজী দীন মোহাম্মদ স্যার, যিনি আমাদের প্রতিটা কাজে, ভালো কাজে, এবং উনি মানুষ বড় ভালো করে চেনেন। উনি চোখের দিকে তাকায় নিউরোলজিক্যাল যে ব্রেইনের সব বুঝতে পারেন, এবং কারে দিয়ে কি কাজ হবে এইটা উনি জানেন। যে এইটা হলো আমাদের প্রফেসর কাজী দীন মোহাম্মদ স্যার। এবং আজকে নিলেন যে ছাত্ররা আজকে ক্লাস করতে পারলো, তারা সৌভাগ্যবান। আমি স্যারের কাছে এটা রিকোয়েস্ট করব, স্যার আমাদের এটা পড়াবেন, এবং স্যার আবার আগামী সেশনে যখন আবার নিউরোলজি শুরু হবে, তখন নিউরোলজির একটা ক্লাস স্যারের জন্য বরাদ্দ থাকলো। স্যার আপনার এটা আজকে অনুমতি নিয়ে রাখলাম, এবং আমরা আগামীতে ইনশাল্লাহ সবাই একদিকে পথ চলবো। মেডেক্সেল একটি মহৎ কাজ সম্পাদন করার জন্য আমরা সবাই একত্রিত হয়েছি। স্যার আমাদের বাংলাদেশের পোস্ট গ্রাজুয়েশনের একটা আমাদের আন্ডার গ্রাজুয়েট শুরু করছিল, স্যার এখন পোস্ট গ্রাজুয়েশনের আমাদের মানে মেন্টর, তিনি আমাদের হেড, পিসিপিএস এর হেড। আমাদের পোস্ট গ্রাজুয়েশনটা দেখেন একটা বড় আঙ্গিকে অনেক বড় বড় কাজ সম্পাদন করছে পিসিপিএস। তো আমি মনে করি যে স্যারের নেতৃত্বে আমরা অনেক এগিয়ে যাব এবং মেডেক্সেল যে মহৎ উদ্যোগ নিয়েছে স্যার, এবং এটাই যে সবার সমর্থন পাচ্ছি এবং আমরা যেন অনেকদিন এটা চালিয়ে যেতে পারি। ছাত্ররা অনবরত বলতে থাকে আমাদের আরো ক্লাস নেন, আরো ক্লাস নেন। অনেক ছাত্র আজকে যারা যোগ দিয়েছে তারা কাজী দ্বীন মোহাম্মদ স্যারের ক্লাস করতে পারে নাই। এই যে আজকে তাদের একটা সুযোগ হলো, এই জিনিসটাই আমাদের জন্য একটা বড় প্রাপ্তি স্যার। এবং এই জন্য নুবিসটা আমাদের যে কারিগরি সহায়তা দিচ্ছেন, অনবরত কাজ করেন, এটার জন্য অনেক কাজ করতে হয় স্যার। এবং নুবিসটাকে আমি আন্তরিক ধন্যবাদ জানাই। কামাল সাহেব আমার সাথে লেগে রয়েছেন, মামুন সাহেব লেগে রয়েছেন, আমিরুল সাহেব, তারা মিলে আমরা সবাই যে কাজ করি। এবং সব টিচারকে যখনই ক্লাস দেই তারা একটু দেরি করেন না। এই জন্য আবারও ধন্যবাদ জানাই। রুবিনা আজকে প্রচন্ড চমৎকার একটা কোহেশনের মাধ্যমে আমাদেরকে একত্রিত করেছেন এবং পেছন থেকে যারা কাজ করেছেন সবাইকে ধন্যবাদ জানিয়ে আজকে রাত্রে প্রায় 11:30 বেজে গেল, 2 ঘন্টার মিটিং হলো। আমি সবাইকে কৃতজ্ঞতা জানাই। আগামীতে দেখা হবে এই আশাবাদ ব্যক্ত করে আমি শেষ করছি। সবাইকে ধন্যবাদ। আসসালাম স্যার।
থ্যাংক ইউ স্যার। আসসালামু আলাইকুম স্যার।
স্যার আসসালামু আলাইকুম স্যার। স্যারের ক্লাসটা কি একটু মেইল করে দেওয়া যাবে কিনা সবাইকে?
এইটা এখন আমরা যেটা হলো ছাত্রদের উপস্থিতি গ্যারান্টিড রাখতে চাই, এই জন্য আমরা এখনো এটা করছি না। আমরা কয়দিন পরে করবো, আবার সিলেক্টেড পেতে হয়তো বা চিন্তা করব। এবং স্যারের এগুলা আমরা বড় বড় স্যারদের লেকচারকে একটা কম্পাইলেশন করে ভবিষ্যতে একটা বই করা যায় কিনা।
স্যার অন্তত প্যানেলিস্টদেরকে দেন স্যার লেকচারটা।
এই তাহলে ছাত্ররা
আমার মনে হয় যে স্যার এটা স্যারের পাওয়ার পয়েন্টটা দেওয়া ঠিক হবে না, তবে পিডিএফ ফাইল করে দিতে পারেন আমাদের।
এটা আমরা ভবিষ্যতে চিন্তা করব এবং এখানে আশা করি ইনশাল্লাহ এরকম নেব। এবং কয়েকদিন আগে আতিক স্যারও একটা চমৎকার ক্লাস দিয়েছেন। তো আমরা আশা করব যে ইনশাল্লাহ আমাদের সব যে টিচারদের ক্লাস অনেকদিন ছাত্ররা পায় না, অনেক ছাত্র দেখেই নাই যে স্যার কিভাবে ক্লাস নেয়, এইগুলো যে আজকে আমাদের সম্ভব হলো। তো আমরা স্যার আজকে বিদায় নিচ্ছি।
আসসালামু আলাইকুম স্যার। আসসালামু আলাইকুম স্যার।
সবাইকে ধন্যবাদ।
আসসালামু আলাইকুম স্যার, ভালো থাকেন, আল্লাহ ভালো রাখুন।
আপনারা কি দাড়ি রেখে দিলেন নাকি?
স্যার চেষ্টা করি স্যার, দোয়া করেন স্যার।
হ্যাঁ ইনশাআল্লাহ।
ইনশাআল্লাহ
পোস্ট হজ তো এটা পার্মানেন্ট মনে হচ্ছে।
ইনশাআল্লাহ ইনশাআল্লাহ।
আল্লাহ ভালো রাখুন।
আসসালামু আলাইকুম স্যার।
আসসালামু আলাইকুম
সবাই আল্লাহ। আসসালামু আলাইকুম আজাদ ভাই। আসসালামু আলাইকুম।
ওকে রেডি হয়ে যান, মাস্টার অফ দ্য মাস্টার্স। ক্লাস আমি খালি ক্লাস চাই, আমার কোনো কিছু এখন আর চাওয়া নাই, আমি খালি ক্লাস চাই। স্যাররা ক্লাস নেবেন, ছাত্রদের শেখাবেন, আমি খালি এই চাই। আপনারা কোনো তুলতে পারবেন না যে আজকে আমার ওই কাজ কালকে ওই কাজ। যদি একবেলা নামাজ যেমন পড়েন এরকম সাদকায়ে জারিয়া পড়াই দিব ইনশাআল্লাহ।
আল্লাহ কবুল করুক।
আল্লাহ এই আমার বক্তব্য, সবার কাছে আমার এই রিকোয়েস্ট যে এইভাবে পড়াইতে হবে। ওকে ইনশাআল্লাহ। আসসালামু আলাইকুম।
ওয়া আলাইকুম আসসালাম।